I'm trying to stay. A slight technology mishap. Sorry about that, folks. So thanks again, Rachel, for the handover, and welcome everybody to today's webinar. What we thought we'd do is just do a very brief background check, just to make sure everybody understands the issues that we were facing and the goods that we're looking at. And I'm just going to ask David to talk to that very briefly.
Sure. So I'm aware that in the audience today there's a mixture of people with education that means you know a lot about neuromuscular blocking agents, some pharmacists, some anaesthetists, so I won't go into great detail. Suffice to say, neuromuscular blocking agents, they're a class of medications that we would use routinely in anaesthesia practice, certainly. We often refer to them as muscle relaxants. I think that perhaps they're more accurately described as producing a reversible paralysis of skeletal muscle, and that becomes important for understanding their risk. As well as in anaesthesia, we would anticipate that they were used in other critical care environments, and so that might be in the intensive care unit, it could be in an emergency department, it also might be out in an ambulance, and we would use these medications to facilitate the management of respiration, breathing, ventilation during anaesthesia. They might be used in an emergency setting, and they might be used to facilitate surgery, for example, and make that task easier. And they are used, we would estimate in Australia there's, approaching 4 to 5 million episodes of anaesthesia care per year. And we would think that approximately half or slightly less than would involve the use of one of these neuromuscular blocking drugs. And so that means that they're widely used, they're out there in the community, but mostly in those critical care settings.
I think that's an important point, because from a non-medical perspective, from a scientific perspective and a regulatory perspective, understanding how these drugs are used is very important when we're looking at safety. So maybe that's a good throw to exactly what are the issues, the safety issues that arise with the use of these particular class of drugs. Amy?
Yep. Thanks, Jenny. So currently in Australia, the labelling and packaging of neuromuscular blocking agents does not differentiate from other medications. And as David explained, neuromuscular blocking agents are unique in that they have the opportunity to be, they're a dangerous medication. They paralyse breathing, and the patient included, and the settings that they are administered in theatres. And at our organisation, we experienced an inadvertent neuromuscular blocking agent administration error, and after this, an extensive review of the incident was undertaken, where one contributing factor identified was that the NMBA lab ampule, I'll term neuromuscular blocking agents as NMBA, it looked like the other ampule that was intended to be administered, and as a result, an extensive review was undertaken, and both immediate and long-term actions were decided upon. And the immediate actions relied on pharmacy and the anaesthesia department working rapidly to strengthen our safeguards with neuromuscular blocking agents to prevent an inadvertent error happening again. And this aligned with the medication management process for neuromuscular blocking agents in the hospitals. So this was from supply to purchasing to administration. And
I think what you've captured really nicely is that there's this, it's a whole process.
Yeah.
But this key risk that we worry about at the front end is that an administration error of this class of medications can have catastrophic results. So the one that anaesthetists would be familiar with from our own literature, unfortunately, and also talking to colleagues, is where an agent that is designed to reduce anxiety before surgery, for example, it is intended to be administered, but accidentally, perhaps because the labelling on the ampules was indistinct, an awake patient receives a neuromuscular blocking agent, and that means that they're at risk of paralysis and being wide awake. Best case scenario for that person is that it's the most terrifying event of their life. The worst case scenario is that it can result in death. The paralysis of the respiratory muscles has obvious consequences. We are fortunate to some extent that this group of medications are used predominantly in settings where we're able to manage that. So an anaesthetist would use these drugs safely every day and would look after patients who are not breathing safely every day, and so we can recognise and respond. But that patient experience of that potential error, is at the heart of everything that has followed since.
Yeah. And if a mix-up error happened outside of anaesthesia, accidentally, because the ampules and vials do look alike, then the outcome where ventilator support is not available, the outcome would definitely be catastrophic. So that's why having safeguards across the medication management process, what we implemented as immediate action is key to safeguarding this particularly dangerous drug. And importantly, just leading on, our long-term strategy after our inadvertent administration error was to develop a submission to the TGA. And this submission was called the Time for Change, Proposed Safety Improvements to the Labelling and Packaging of Neuromuscular Blocking Agents. And we really wanted at a national level to differentiate these drugs at NMBAs from other drugs. And this submission involved a review of Victorian NMBA incidents, and what we identified was that a common contributing factor was the lookalike packaging, but importantly we only had 13 incidents, so the number of incidents wasn't great, but as we've discussed, an outcome of an NMBA incident is catastrophic.
And I think you're touching on a really important point, which is, is this a problem? At what scale is this a problem? And I think if you're looking at a population level, the extent to which an issue is important to tackle, you need to look at a denominator of how many times these drugs are being used. And it's approaching 2.5 million times a year.
Right.
Now, there's a lot of controversy about the rate of medication errors, particularly in anaesthesia contexts. It's very difficult to measure this accurately. We commonly rely on reporting systems, voluntary reporting systems, which we know will typically underestimate a true event rate. When you're also assessing this population level impact, it's not only that denominator of how many episodes, it's what's the magnitude of impact for any individual. So even if it only has happened a few times, it's potentially catastrophic. And we know that's well reported in our literature.
And that's an important consideration for us as regulators, to understand the risk. And that's not something that we can do easily. So being presented with the data from Amy and her colleagues is an important part of us and our consideration as to the best approach that can be taken. And that involves a lot of consultation, which I think is one of the key points that we'd like to raise and discuss here. And yeah, that consultation process kicked off a number of years ago with this report that Amy and her colleagues have put together.
Another thing that oh, sorry, Rosemary, you go.
I was just going to say the other thing is that a lot of hospitals have adopted similar sort of storage strategies, separation from other stock, labelling, but it's actually not consistent, and clinicians move from hospital to hospital, so what's in place at hospital A might be totally different at hospital B and C, and with anaesthetists as well, they'll often have appointments at multiple places. So one of the really good things about this is that consistency across wherever you are actually going to be.
Absolutely, that acknowledgement that standardisation is part of an effective intervention strategy is key to this change. And we know if you assess intervention effectiveness along a hierarchy, at the bottom of the effectiveness table are things like education or telling people to try harder or read the label. We've been doing that for 20 or 30 years. At the very top of that pyramid is a force function where you just cannot, for some engineering, mechanical, chemical reason, make the mistake. That's not achievable. But in the middle, and becoming more and more effective, is standardisation. And so the engagement of the TGA as Australia's peak regulatory body enables us to achieve that at a truly national level. So it isn't just individual hospitals adopting unique labelling practices. It's an Australia-wide change that will affect the presentation of all of these drugs. And that's a massive shift towards using design principles to achieve that standardisation and the safety that results from it.
Yeah, so I guess just again to fill in the audience so there's a better understanding of our role in this. Once this was brought to us, to our attention, and looking at the developing a best regulatory approach, it's about gathering all relevant data so we can make an informed decision. And in this particular instance, given the unique situation that we're trying to address, we took a roundtable approach. So we invited the interested stakeholders and the users of the medicine, so the pharmacists and the anaesthetists, relevant professional bodies and the industry. So these are the people who supply or manufacture these types of medicines for supply in the Australian market, to understand exactly what forces were in play here. To cut a long story short, this ended up in an agreed approach, which was terrific. So when we can get all the stakeholders to reach a position of compromise, we do recognise it's a compromise, but that in itself I think is a good thing. So the compromise was to identify these agents with use of a particular colour, and the colour selected was one that was used in similar situations already in the system. So again, we go to that systemised approach and consistency. And then the warning statement, and developing a warning statement that's meaningful for the people who will be using the medicines, but similarly recognises the constraints in the manufacturing processes. So we have a number of different statements which hopefully achieve the same effect but recognise some constraints. So longer statement on where there's sufficient real estate on a label, smaller on the small containers and vials. I guess the other thing that people need to understand, both in the terms of what you're going to see on these medicines, is that you won't see it immediately. Whilst this legislation was passed and is in place, to allow industry the time to implement these changes in the manufacturing lines, we must give a transition period. So some manufacturing will be able to implement a change reasonably quickly, and you might see products or batches of an existing product with these new labels reasonably quickly. Some others you may not see. And there will be that transition time in the marketplace. And I think that's very important for users to understand what they're going to see.
So that transition time could come from now to 2020.
Correct.
So quite long.
Yeah.
At least 2 years.
That's right. So we've already got some reform occurring with medicine labels, and that has a transition period that ends in September of 2020. And what we're able to do is coordinate this additional change with that timeline. So at the end of September 2020, all new medicine labels must have this on. Yeah. But again, there will be that lag time, and perhaps the pharmacists and Rosemary and Amy can talk about what that might look like in the hospital setting.
Yes, so in Victoria we have Health Purchasing Victoria at tender, and one thing that we do with that is the Big Tag Quality Use of Medicines group with the anaesthetists, we look at each drug that's going onto the tender and we review the packaging. So as David said before, any drug that has the warning label on now, it is my personal opinion and my professional opinion that we would probably most likely prefer those drugs that have the warning label on now as opposed
It's
to...
important to recognise, though, that there'll be a lot of stock still in use in many places, and and it's appropriate that that stock is used with the existing safeguards that are in place. I don't know what the experience is in New South Wales, Rosemary?
Well, New South Wales has a similar approach, and I actually think most states do, which is a purchasing for safety, where safety is a weighting. However, for this change, it's actually applying across the class. So I think the big message for hospital pharmacies is that just because this has now passed and this is coming, we don't actually stop all our other safe storage methods, and then as the products come through and get changed, we risk assess as to what our approach is. But it's not going to happen overnight, but I do think it's a big step forward.
And I think that acknowledges that it's one part of the system that you're referring to, and none of those system strategies should be discounted because of this incremental change. You know, we are here using design to advantage, but whilst humans are involved in this process, we can expect to be vulnerable. And so those systems that separate dangerous medications, those systems such as the red-barreled syringes that clinicians will be familiar with, the unique labelling requirements within hospitals, other administration rules, they must still be a part of what we do until such time in the imaginary future where we don't make mistakes.
Yeah, and I think that's sort of, well, going back to our consultation process and the roundtable discussions, a lot of the recognition I think that has to happen with the supplier of the goods is understanding how they're being used in the actual setting, the hospital setting. And then what they can do to facilitate that. And one of the considerations for us as regulator is that we don't introduce requirements that are overly stringent, such that we restrict supply. So this is a consideration in what can practically be achieved and would meet, coordinate, I guess, with what's going on in the hospitals.
And always a key component with our correspondence with the TGA was that the labelling update will you know, having that standardised at a national level will support the current hospital initiatives in place at our healthcare services.
Jenny was touching on it before, but that the TGA should be congratulated for their role in coordinating so many groups. So in these roundtable conversations, and of course many of the offline discussions, were the peak health groups and the users, such as the College of Anaesthetists, the therapeutic advisory groups representing pharmacy and quality use of medicines experts, and then bringing industry into it under, you know, the TGA umbrella just made this very real, and it helped us communicate the place and also understand that the balance of what's possible and what's practical to address those things that you alluded to, such as the unintended consequences of supply shortage, or so in collaboration with industry, we've been able to say this is achievable in this type of time frame, and we think it's a meaningful step forward.
That's good. What about your experience, Rosemary?
Sorry. Oh, and making it something that industry could achieve, because the other potential issue was whether we would lose some players in the Australian market as well. And so I think that I attended that round table, and it was a unique opportunity for everybody to understand the other perspectives and try and come up with something practical.
And importantly, with the round table, this is a good example that the TGA can lead the way for other countries with a similar Australian market to have this warning label on NMBAs, because incidents aren't just happening in Australia, they're happening worldwide, and yeah, that would be a really good thing.
Okay, I don't know any of the panel might like to talk to this, but I think it is important to understand what other approaches have been doing. So yes, if the labelling requirements are going on the primary packaging, that's occurring during the manufacture of the goods. What actually happens though when that arrives in a hospital setting at the point of use?
I think some of this is actually covered by one of the professional statements or a guideline produced by the College of Anaesthetists about the safe handling of medications used in anaesthesia settings, the principles of which would apply to those in other critical care environments. And it starts with procurement that Amy discussed earlier, which is choosing safe products to enter the system. It includes the storage conversations. Don't store these in places where they're not going to be used. Making sure that where they are stored, they're clearly flagged or separated as recognising their risk. And it addresses some of those things that the pharmacists are already experts in, that end of the process.
And yes, to complement ANSCAR's guideline, through VicTag, with one of our correspondents, we undertook a survey of Victorian hospitals and what they currently did as safeguards across the medication management process for NMBAs. And what we identified was hospitals are doing a lot. However, what we needed was a standardised. We need to centralise these recommendations. So VicTag are currently funding a project to undertake a safer practice advisory tool for currently for Victorian hospitals, but it potentially has the opportunity to be shared broader. And this covers, we've got an advisory group set up which involves specialist anaesthetists, medication safety pharmacists, and pharmacists specialising in critical care areas as well as nursing staff. And it covers all the critical points of the medication management process specific for NMBAs. And importantly, it also addresses when the labelling update comes into play. We've got recommendations for NMBA storage and supply after the labelling comes into place. So definitely the idea is that hospitals maintain what the current safeguards that are in place, and this is an extra safeguard for labelling to put on top of this. And
so it's interesting that you're doing the reviews and assessments, and I'd imagine, Rosemary, that that's occurring in New South Wales as well. And that sort of leads to the consideration. So as a regulator, we've changed the requirements. How can we measure or tell whether this has actually achieved what it's supposed to do?
And that's a really important question for any intervention. You know, as a scientific question, you like to measure
absolutely
the impact of change, particularly where change is difficult and or expensive. We're fortunate in Australia and New Zealand to have a web-based anaesthesia incident reporting system, which we hope will be a mechanism for us to track change related to this sort of class of medication errors. But there's a certain truth around the difficulties with measuring rare events related to medication administration. So it may be that it's very difficult to capture. And then it sort of begs the question, well, if you can't measure the change, did it ever happen? And I think even though we may not have the evidence in a specific drug class.
And is that particularly important for this particular class of drugs? If you're saying already the numbers, if you just look at a number, is reasonably small, that's a particular concern in this type of situation.
Yeah, but I do think that we may not get concrete evidence in this space as much as we would like to try. But there is evidence everywhere about the influence of design and safety, and you can use all sorts of analogies. If you went to the supermarket and tomato sauce was sold in a range of different coloured bottles, the next time you were at a barbecue, you pick up the yellow one and you get tomato sauce, and you'd be disappointed with that. So this is like us saying that all tomato sauce will be in red bottles, and that's a light-hearted thing. The consequences of neuromuscular blocking agents is clearly more significant. But it's that. We know there's evidence in human factors research. We know there's evidence from engineering fields about the influence of these standardisation changes. So I'm confident it will result in incremental change for the better.
Yeah, definitely.
And I think, I know we have a few medicine suppliers and sponsors in the audience, but even if you weren't there, I think it's important to acknowledge that we contacted all the suppliers of these types of goods in the Australian marketplace, and they were very open and willing to provide labels that work for the consumers, in this particular instance the health professionals of the consumers. But again, they want to make sure that their medicines are used safely and appropriately. So they're an important part of this discussion about what could be achieved to assist in realising that benefit.
Yeah. And that's why the roundtable was really good, because we all came to a consensus at the end, and everyone was in agreement that this labelling update needs to change, including industry, which was really good. Very good.
The other comment I'd like to make about, I guess, the on the ground in hospitals is I notice there's quite a few questions at the moment to do with drug shortages and bringing in products from overseas which will not have these labelling standards, so that on the ground we need to remember, if we change our risk management approach by this new labelling, that we need to be able to reintroduce it if we are buying in different products from overseas and such like, that we can't lose the current safety messages, methods and messages.
Okay, so maybe that Rosemary's alluded to the fact that we can see lots of questions coming in. Thank you very much. I'm going to ask one of my colleagues just to read some of them out and then ask the relevant panel member to answer them. That way it's more of a conversation instead of us talking to ourselves.
So one of the questions that with the labelling requirements, are there safeguards in place to prevent stock shortages while the manufacturers make change their labels?
That's a good question.
So I'm happy to answer that from a regulatory perspective. Well, there are two things, I guess, to acknowledge here. Well, firstly, we involved the suppliers of the medicines in those conversations to ensure that we had in place an appropriate transition period so that their supply was not affected. That being said, there are always other factors that can affect medicine supply and shortages. We've recently had some changes to notifying shortages, which we will hope to go to that. So I guess the short answer is we took that into serious consideration as part of this activity and did the best we can to minimise the possibility. I don't know if anybody in the hospital pharmacy...
I mean, if it does happen at a healthcare service, that's where we really want to let the end users know before the out-of-stock problem comes in. And it's about letting the intensivists and the anaesthetists make them aware that a new product's coming in. And that's where the current safeguards, like the purchasing for safety or procurement safety processes within your organisation, really come into play. And, yeah.
So sort of a two-part question. So additionally, there are sort of a two-part question. So additionally, if there are future shortages and we are required to access stock from overseas, for example, by SAS, will that stock be required to be labelled in a similar manner as well?
I'm getting lots of regulator questions. The short answer to that under the legislation is no. Goods brought in under the Special Access Scheme are not subject to our labelling order. That being said, the emphasis then flows to the activities that Amy's mentioned, and perhaps Rosemary as well can talk to how, because that would occur with anything that comes in under the Special Access Scheme. It may well be labelled differently to what the equivalent Australian product would be. So it would be, again, internal protocols looking at that.
And to add to that as well, so with one of the current recommendations that not a lot of hospitals can facilitate, but if one product was to become out of stock, there are BAPAC warning paralysing agent labels available that can be ordered, and for this one product potentially pharmacy could adhere this to that ampule or vial so that it does have the warning label on it. That's one option.
And I guess that's what I was alluding to, that we need to remember what safety procedures are in place now and reapply those when new stock comes in, and particularly the overseas stock. And that's pretty much core business these days for pharmacy departments.
Thank you.
Another question here, is there any consideration given to the specific issue of succinylcholine and pancuronium mix-up? Near identical ampules, both neuromuscular blocking agents, but different mechanism of action and time course. Will the new labelling distinguish depolarizing succ from non-depolarizing NMBA?
And also that came up very early on in the process. I think what's important to remember here is that both succs and panc, as we would refer to them, are still both the same class of medications. And so the person administering them is expecting that a patient will, have a muscle paralysis at some point. And yes, they are completely different. They are less likely to be involved in a true ample mix-up. There are other issues that I know relate to practical considerations that we discovered with the manufacturers about the real estate available to produce a clear warning label on an ampule that only has a 2 ml volume. And so there are compromises that needed to be made. There are also supply issues to consider, particularly with succinylcholine in Australia. And we've accepted those compromises as necessary to make progress in other ways. The future might hold something different, but the balance of the other unintended consequences was more important in this circumstance.
And I think the only additional thing I'd say to that is we need to be very careful when we're trying to come up with a regulatory solution as to what is the actual problem we're trying to address. And in this situation, we are trying to address when the administration is where there was no intention to provide a neuromuscular blocking agent. So it's distinguishing the class of goods from other medicines, not between. So I think they are both important, but subtly different and potentially need different approaches.
Yeah, I agree. The fact that the pancuronium and succinylcholine unfortunately look similar, they are the same class, and it was a different problem. That was established in the round table as well. So the focus was to have the warning label specifically on all NMBAs, and and that was what we aimed for at this stage.
Cool. There's a few more questions here. This is an international issue. What scope and barriers are there to exporting it? Is there a risk of shortages from international drug companies deciding to leave the Australian market rather than changing their product?
Well, so the reason why the Australian market isn't the US and Canada, and a key thing that was brought up at the round table was that manufacturers had a say on what the labelling can look like for the warning label on NMBA ampules and vials, and the TGA worked closely with manufacturers. So with this, we're not really experiencing. We're not expecting a shortage.
No,
because they're going to leave the market.
Exactly. So that was one of the key considerations to make sure that we weren't introducing something that was overly onerous. Can't say that. That was sufficiently onerous that it would discourage supply to the Australian market. So that was a very important consideration.
As far as exporting it to other countries, I mean, this is beyond my area of expertise, but you would think that the model of what has happened, the process that has led to this change, if we determine in a number of years that it has in fact produced, improvements in the way these drugs are handled and recognised, it's very exportable as an idea, and we should be proud of that. That achievement.
Definitely.
And I think that goes to market-driven change. So if the users of the goods are saying this is what they need, articulating that and raising that with the suppliers, because for them it's both a commercial thing as a safety. They want people to buy their goods because they are the ones on the market that people want to use. So they're going to be open to achieving what is benefit.
And some questions from the audience also allude to the fact that it's not only international, it involves other medications.
Absolutely.
I know a web link will be provided to the Easy Drug ID website, which sort of highlights the international and broad nature of this issue. And that was set up by an anaesthetist colleague of mine, Nicholas Crimes, in Melbourne. I'd certainly encourage people to use it as a resource in understanding the breadth of this issue.
So, as mentioned, real estate on the packaging is important to allow for appropriate labelling and coding. But so many drugs these days are presented in tiny glass identical ampules with very limited space for labelling. Should we push for bigger ampules to allow for better labelling and coding?
I think the users of the medicines, I think, again, that comes to market forces. It goes to, if we want to keep, if those particular medicines are only currently supplied in glass ampules, we need those medicines in supply in Australia. Therefore, we're not saying you can no longer use glass ampules. However, if the users of the medicine, given the options, are selecting different presentations, that then drives the marketplace. But I'm speaking from a completely theoretical point of view without knowing what power you have in terms of selecting goods at the pharmacy.
I'd say one step at a time.
Yeah.
Is a perfectly reasonable approach. These things we need to consider. And I think also there's room for imagination in this space. We are, of course, choosing a path that's based on what's possible and achievable, but the real advances may be in the future where people are designing medications that are genetically locked to an individual, or the nanotech prevents their activation unless a patient is unconscious. That kind of exciting stuff, and the way we move beyond just how we present the medication. That's the future that awaits. But baby steps.
So we've had this next question a couple of times. Question is, what will be required for labelling if an ampule is removed from the box and stored separately elsewhere, for example on a resuscitation or intubation trolley?
So this is a really important part of what people need to understand, is that the labelling standard that's articulated by the Therapeutic Goods Order actually requires that the ampule itself will leave the manufacturer with the warning statement. So this is not a request for a third party to add a warning label. We're not going to ship them with a box of labels. The companies have really stepped up to the plate, and they produced a change where this will have a label on it from the moment it leaves the factory. So it will be labelled as a paralysing agent on its actual ampule, not just the primary packaging. And so when it's sitting in a resus trolley, or when it's sitting in an isolated space in an emergency department, it will still have that warning label. And I think that's a massive strength of this change.
And those hospitals that are like individually labelling glass ampules and vials with the warning label, after the introductory transition phase, that won't be needed, I don't think. Yeah, that's my opinion.
Is there another question?
Yes. This one goes back to our colour coding. So colour is an important method of coding, but is not a panacea, for example, for colour blindness, and limited colours are available. What about other coding measures, ampule shape, texture, barcoding, QR codes, etc., to distinguish between neuromuscular blocking agents and other drug classes?
I looked some fantastic points, and it goes to the imagination component of what I was talking about before. You're absolutely right that colour is a limited design tool, and that's why it's, of course, in this setting combined with clear warning text with specified minimum sizes and a sort of a clear statement. But nonetheless, colour is used, and both consciously and subconsciously we respond to it. You know, an octagonal sign that is red with white writing on it is most likely to make you want to stop, and it's because you've already made that association. But it's important to also say that the colours are already subject to an international standard, and so that labelling standard means that there is consistency now across the world, and certainly across Australia, that has drawn heavily on that ISO standard.
And from the time for change submission, we did want the labelling and packaging of NMBAs to all be in vials. However, at the round table, it was established, and this was discussed earlier, that the Australian market manufacturers can't facilitate updating all their labelling and packaging to vials for NMBAs. So the consensus was that the warning label be on the ampule and glass vials that are available currently in Australia. And this is important, that it's to also maintain supply to Australia of NMBAs, and it was a cost-effective measure and safety as well. So they both measured each other out. And yeah,
I was just going to say, I note there was also a reference in the previous question to barcoding as something, and there's certainly been some research in this space, and the idea would be that an anaesthetist handling a medication would barcode scan it, and it would read it out to you as a double check mechanism. There's some research. It has never taken off, I think, for some practical reasons, and it's largely fallen by the wayside as an effective strategy to manage this problem. It also only checks the ampoule to syringe stage, and it doesn't check subsequent parts of the process, which we are unfortunately still responsible for.
So I think that goes to, again,
existing systems,
multi-component approaches.
Absolutely. Yeah. There have been other strategies internationally that have been researched. For example, a double-checking strategy in the United Kingdom. That there was a hospital that went for a 6-month period where they had 2 users check every administration and preparation of medication administered during anaesthesia. Over the space of that period of research, I understand there was not a significant reduction in events, but the workability of that as a solution was found to be lacking. It was difficult, and it's enormously resource intensive. And anaesthetists will know that we might be, administering a number of medications in rapid succession. You might need to do that immediately. So the second person check, the barcoding process, they haven't ever really taken off as effective measures, but they're important to consider.
We have a few more questions that people gave us prior to when they were registering. So one of the questions is probably for our TGA. Does the TGA intend to do any usability testing of the labels?
The short answer to that is no, and it goes back to the approach that was agreed is consistent with the colours that were already being identified and used for these types of goods. And I guess, potentially user testing, there was an agreement from many of the representatives of the users of the medicine as to what was meaningful to them. So was it user testing in the professional sense of the word? No, it wasn't, but it was a selected testing of proposals within that group. So again, it goes to what was practical and achievable that we could do in a reasonably short period of time. If we could come to an agreement as what was going to be useful for the people who are actually using the medicines, then that was an appropriate way to do it.
Jenny, I might ask you another question then. Will there be any future improvements to improve labelling of NMBAs in plastic ampules?
At this stage, no, we don't. But there always seems to be changing goods in the marketplace. There are always changing technologies. The barcoding, I think, is a very important one that we're looking at from a regulatory perspective for a lot of different reasons. Track and trace, counterfeiting, but also better use of data within the health system in the big picture. So I think things are always changing, and it's inevitable that we will be revisiting this at some stage. Perhaps from the specific context of improving the safety of these class of goods, or potentially as a consequence of some other approach. So in the short, at the current stage, no, but I would not ever say never.
We have one more question from the at the time of registration. It's probably for David. How will this affect our day-to-day practice in anaesthesia?
So the short answer to that question is that hopefully the impact it will have on you will be as much subconscious as conscious, that these labels will be part of the design trigger that helps you select and confirm that the agent you have in your hand and are putting into a red-barreled syringe is in fact a neuromuscular blocking agent. In real terms, you will go to work, you will use these medications, and you will not experience sort of a concrete workflow difference. And I think that's also an important outcome, that there'll be benefits there that perhaps you won't realise, but that the impact on workflow will be very limited. Okay,
I think we've come to the end of our session, so I'd like to thank Rosemary Burke, who's been online, David Bramley and Amy McRae for their help and assistance with this and the positive outcome.
Thank you.
Thank you.
Thank you.
Thank you, everyone. Just a reminder that this webinar will be placed up on the TGA website at tgaww.gov.au under the Newsroom and Events tab. Thank you very much for your time today. Thanks, Rosemary.